Hi MSers, it's Dominic from the msguide.com. Today we've got a really interesting chat. It's with a neurologist, but hopefully it's not too doctory. It's about prescribing to patients, about picking a high efficacy meds. It's about the whole process of diagnosis and what it's like for patients and slightly for doctors and also nurses, because there's lots of us involved in this. Anyway, she's kindly given us her time. It's Dr. Ide Smets from Bart's in London. And that interview is going to start right now. Hi, everybody. I'd just like to introduce you to Ide Smets. She's a neurologist. And rather than me talk, I'll let her introduce herself. Ide.
So hello, everybody. I'm Ide Smets. I'm a neurologist from Belgium, and I'm currently employed at the Royal London Hospital in London. And I work with Professor Giovannoni, with Klaus Schmierer, and all of their colleagues. So
that's brilliant, Ide. Thank you. And I've got to say, anybody, if you're not subscribed to the Bart's MS blog, it's a great place to find things out. And Ide certainly writes the occasional article there. Ide, I didn't want to talk about the old doctor, what about this, what about that stuff. I was far more interested in trying to turn it around and talk about what it's like to be a doctor that has to say to people on a pretty regular basis, you have an incurable illness, it is likely to disable you. You will now be coming to hospital, I don't know, every 3, 6, 12 months, whatever. And to me, that has to put in some sort of emotional burden, should we say, on the clinicians. And I was hoping you could talk a bit about what it's like from your side of things there.
But I think personally it goes in little baby steps. So it already starts when people have their first symptoms, so they wonder what it might mean or whether it might be a part of a bigger disease. And so it's an entire process, but it's not something that happen. Your diagnosis doesn't happen overnight. So people they know something is going on, they research a little bit online, and then at a certain point everything comes together and matches MS diagnosis. But very often, for the majority of the people, they've already seen 1 or 2 consultants at that point. So it's not an acute communication. So that's first of all. And so also the insights in terms of how it will impact on their life, it's also not something that you grasp at that very specific moment. So I think many people at that moment even have some sort of relief combination with anxiety. So they're happy that it's now clear that they can fit in a specific box, which is obviously valuable in terms of treatment and prognosis. But then there is also this whole new line of questions that pops up, and that the fact that there is uncertainty about the future. But I guess it's a very chaotic moment that many people don't remember very well afterwards. So yeah, I think it's just important to have several encounters with people, so that they can adapt to the idea of having this diagnosis, and that they also see that actually also nothing has changed overnight. On the other hand too, because it's not because you have the diagnosis that you're different from yesterday. So I guess that's insights, and that in 2 months there will be a difference. So it's a chronic disease that doesn't have, in the majority of the people, there are no implications for the week after, the month after. So I guess that is the most important framing that is necessary at that moment.
So what about you? What about your colleagues? Do you ever sort of sit down in the staff room, so to speak, and talk about what it's like to, because ultimately as the MS neurologists, you're probably the people that say, I'm very sorry that I have to tell you this. All these things that you talk about that have culminated in you sitting in front of me means that I have to confirm to you that I can now say absolutely that you've got MS, and you're effectively delivering, whether or not it sinks in immediately, but you're delivering life-changing news to people about their health. What's that like for you?
But many people see it coming. So for many people, it's just a confirmation of their own suspicion.
Mm,
And yeah, I think I try to emphasize that essentially it has no immediate implications, but that we need to think about the next years, and that in that respect, treatment will be very important.
yeah.
And then personally, I think then you connect the diagnosis with
Mm,
a perspective of halting and disease and inflammation. And also maybe at that specific moment, you're not ready to make the decision between all the different DMTs, so all the different disease modifying treatments. I think at that moment, it's nice to hear that it's a diagnosis and it's treatable to a
yeah.
certain extent.
Oh yeah. No, I'm just thinking from your perspective. Let's say I'm maybe oversimplifying this. If you're an orthopedic surgeon and they've got a broken leg and you have to operate, and your relationship with that person sort of starts here and hopefully ends here, and you can say based on these factors and the style of the break and your age, your weight, your general health things, and your engagement with the physio means that you're likely to regain, oh, I don't know, 50%, 90%, 100% of your functionality. And it's a kind of bye-bye thing. Whereas with MS, you see me in 6 months or a year, and you see me in a year, and I may be fine, I may deteriorate. And I mean, it's a different kind of relationship, because if you're my neurologist, it's because I kind of live somewhere and I've been diagnosed, and then you and I are thrust together in this relationship where you may well have to watch me get sicker. And I just wonder how challenging that is for you and your colleagues.
Yeah, I think for me personally, so I'm not really in the stage where I have a whole repertoire of people that I follow for a decade.
Right. Okay.
So I have to admit that for the majority of people, I have one-off encounters. And yeah, obviously it's very clear to me. I can also read, and
Mm,
so when I see what has been documented in the previous letters, and when I see them, when I meet them, it's very often apparent that a lot of disability has accumulated over the past years. So it's not, obviously I also notice these kind of evolutions, but admittedly I don't have many people myself that I have that I traveled through the entire disease
yeah. Yeah.
with them. So that's not something that I have experienced so far.
Right. Yeah. You're okay. This is my ignorance now regarding your career as a doctor, because you're over here in Barts. Do you do a year, 3 years? I don't understand, because I understand that you don't have this long-term relationship with them.
No, but also in BARTs, it's not always the same person that sees
Mhm.
the individual with MS. So it's kind of, it's sometimes also a bit of an interplay between the MS nurses, the supervisor, and other residents also.
Yeah.
So yeah, it's very often people have not been seen by the same person over and over again.
Mm.
That's more the exception than the rule.
So does that make it, and I don't mean dismissively, does it make it easier as a doctor if you aren't required to engage with something? I mean, if you think about, if you live in the countryside and you've got a GP and they've seen you, they may have seen you being born, and all the
Mm.
way through like that, that's a different kind of relationship than as an MS patient. You land in the hospital,
But
if you will, a big hospital often, with a neurology department.
I think the NHS philosophy is that the element that is continuous in the care of people with MS is the MS nurse. At
Yeah.
least in our hospital, it's very clear that our MS nurses, they are really the pillars on which everything else is built. So it's really true that they are there for day-to-day
Yeah.
questions and for practicalities. So they are the ones that provide continuity. And then we as
I
physicians
agree.
unfortunately are more there for when there are issues that the MS nurse cannot solve.
Right. Okay.
um, so that, and I think in many academic referral centers,
Hmm.
because that is what parts MS is, it's not a first line, it's not a second line, but it's a sort of third line center.
Hmm.
This is how it's organized. And
Yeah.
indeed, yeah.
I've got an awesome relationship with my MS nurse. He's fantastic. And I've been at Oxford for quite a while, and I had one nurse before him, and then they've moved. She's moved into research, but she's still
Mm-hmm.
there. I bump into her occasionally, say hello.
Mm-hmm.
But yeah, it is. They I think could better say what's going on with patients' lives, mine or whatever.
Mm-hmm.
And I got divorced some time ago, and obviously that's traumatic, however you slice it. And
Mm-hmm.
but they were there, and I didn't want to
Mm-hmm.
think it was affecting my MS. And one of them sat me down and said, "Don't be an idiot. Of course, any stress does." And so, okay, but you're right. Yeah, I'm not trying to force it on you. It just struck me. It's curious because to me, it's the giving the diagnosis, and I just think, good grief, what it's like, to. I used to be in the police a while ago, and when you have to knock on somebody's door and deliver some very bad news to them, it also
Mm-hmm.
affects you. It's not fun, and nobody else is going to do it. Ultimately, you're at the top of the pyramid for, okay, now you tell them.
No, but obviously it's not the same as diagnosing somebody with cancer.
Yeah,
So I think that happens very often much more overnight,
right.
because then you have, for example, blood in your urine, or you cough blood, or whatever
Yeah,
kind of symptom you have. You do a scan and it's
yeah,
there.
yeah. Oh
So
yeah,
it's not exactly the same,
sure.
and cancer kills. This is so the I wouldn't say so I guess the impact might be bigger on in the long run, but
Hmm.
in the short run, people just don't know what to expect initially, and that kind of softens the message, or softens the diagnosis, because
Yeah.
it's vague, and indeed it's really
Hmm.
vague, and there is so much stretch on how it will impact an individual's life, that
Hmm.
yeah, that there are very good scenarios and very bad scenarios. In cancer, it's very often all bad in the beginning, because if you have to overcome chemo
Yeah.
and radiotherapy, it's all bad. But for MS, it's much more. It's a totally different setting. So I must say that the big emotional reactions often are not there. It's something
Yeah.
that has to sip in, and
Yeah.
that you only grasp when living for the disease with the disease for months, years. That it's only at that specific moment that you understand yeah what it exactly means.
When I was diagnosed, by the time you're right, by the time I got to the delivery of diagnosis, the actual
Hmm.
fact of the hermits that I was experiencing, that drove me to the doctor, that drove me into the
Hmm.
process, had gone. So I sat there
Yes,
thinking,
indeed.
I feel fine. And this
Hmm.
guy's just, I had gone and read about it. I'd actually read about it
Hmm.
in a hospital library where I was working, but it was just, and I'm thinking, this doesn't look good, but I
No.
feel okay. And but yeah, so looking back, I suppose he's dropped a nuclear bomb on things. But then at the time, it was just okay, and you wait for something to happen, and it's only, I mean, it's 28 years. I've been very lucky, but things have been taken away from me by it. But you only notice almost on reflection. It's not an immediate thing, like you say. It's not like a sudden death or something.
No, indeed. And so there is never the sort of that never is never there.
It's
But I
never
think
there.
you're right. It's that's just I think no, from my point of view, the majority of people is not overwhelmed when they finally get the diagnosis, because it has been a process before, and it will be a process afterwards, and it's definitely not that um existential
Yeah,
as a cancer diagnosis
yeah,
is.
yeah,
So that's why the emotional impact is modest.
yeah.
I would
Yeah.
say,
It's
based on
not the
personality,
psychological
based on
reality.
your own personality, obvious, but on average, it's definitely more modest.
Hmm.
And I think there is just this sort of maybe afterwards when you reflect on it, but not really the day, but in the weeks and months after, it might become more relevant, but or more clear to you what it means, but definitely not at the moment you get the diagnosis.
Yeah, I remember trying to force myself to think about it and take it seriously and think, well, you wouldn't have got to this stage with MRIs and lumbar punctures and neurologists if it wasn't real. But there's this
Hmm.
slight feeling in your head of going, there's an element of unreality to this entire thing. And I'm trying to force myself to engage. But yeah, okay, I take your point. I see in some ways, can I pivot and ask you, I know we discussed this slightly before. Can I ask you a question about a slightly different topic? Because again,
Go ahead.
it concerns patients. I'll set up, there's a general view amongst me and most patients I know that as a doctor, you have gained a huge amount of knowledge. By the time you become a neurologist, you know about a lot of things. The only people I think who know more about drugs technically, and I've got a friend who's a pharmacist and they get very upset by this, is pharmacists, because that's all they've studied. But you know, it's with DMTs, and it's sort of split, I appreciate, between escalation and induction. I have a personal view that you don't have a fight with somebody by gently prodding them to start with, and then moving to aggressive hugging, and then eventually knock them out. My view is, if you're going to fight something, knock it out. But that's my personal view. And a lot of people I speak to, though, have had a different introduction. It's like, and these are my words, it's like almost the nurses seem to be kind of scared, and maybe the doctors, I don't know, of saying, take this, because people are being started with MS, which we know is a dreadful long-term disease, on these drugs which aren't as good as other drugs. Yet they're also then feeling like they're being forced to make a choice. And frankly, I would expect you or whomever as my doctor to guide me and advise me, not hand it to me and go, you pick and stand back. It feels
No, but
frightening.
that's also because there are many different options, and these options need to be compatible with your life. Because especially, for example, if you're a young woman and you recently you get diagnosed with MS, there are some of the drugs are compatible with family planning and others aren't.
Yeah.
And so some people also have like a needle phobia, or don't want, so hence they don't want infusions. So there are some, so that's why I think it's important in the setting of MS that the decision about disease modifying treatment is made in close discussion with the individual, because they in the end need to do it. So if you don't get them on board, and obviously from a medical point of view, it's only the treatment that is most efficient at hammering or at halting the inflammation that it matters. But what are you with a treatment that people can't put up with? So then it's maybe medically it was useful, but if people don't cannot tolerate it or are not motivated to integrate it into their daily life, then you've done nothing at all. So that's why I think it's really important that people, that you engage with individuals about what it would mean for them. But obviously, this doesn't mean that you give a list with 3 names on and that people need to figure out themselves how to deal with it. That's not what I'm saying. But I think it's logic that people get several options. Then you need to point out to what extent they will influence important life decisions such as family planning, traveling, and to what extent they match with with somebody's personality.
28 years in, some people seem to, in my view, misunderstand, or because, as we were talking earlier, sometimes very little's happening to you and it's kind of hard to be bowled over, just how insidious and serious MS can be. So there's one aspect of communicating to people just without, you don't want to frighten them to death, because that's pointless. And very few people do things when you sort of put a gun to their head like this. They will say yes, but they will walk off and not do it. And I was speaking to another doctor I know who the patient was just saying, oh yeah, no, I've absolutely been doing it. And when they tested their bloods, they came back and said, well, it's been at least 6 months since you've absolutely done it every day. And the patient just caved and said, oh, I didn't want to upset you, doctor. And they're thinking, crikey, you're not doing this for me, you're doing this for you. And so there's all these complex psychological things.
First, it's about making people understand that a treatment will alter their disease course. And second, it's about deciding on which treatment they have the biggest chance of uh, of keeping up with. So for yeah, which treatment matches best their
Yeah.
personal goals and life. So
Mm.
those are two different aspects. So first, it's indeed important that people realize that a treatment alters their disease course and that it makes a significant difference in their odds of being able to walk in 10 years from now.
Pretty
That's the
important, but hard to conceptualize, isn't it? When you're walking fine now, the idea of
Yes,
not being able to
that's
walk.
indeed that's difficult to conceptualize, especially as all your so after a relapse, you most of the time, especially after first relapse, you largely recover, so
Yeah.
you go back to normal. And so all your senses or all your logic tells you, I'm doing good, why wouldn't this be a one-off thing? And so then it's again, yeah, sometimes you have to believe in science and believe believe, yeah,
Yeah.
or even when it doesn't, kind of when it conflicts with your own impressions. And so that's obviously a talk you would need to have with the person in front of you and understand what their beliefs are in terms of, or to what way they are maybe too positive
Yeah.
about their disease and about what's happening to them. But that's obviously before you start cherry picking the different disease modifying treatments.
Mm. I suppose it's the same as telling people to lose weight and exercise when they're younger because they can't conceptualize about being 60 and possibly having a heart attack or joint problems, etc.
Yeah, these are hidden harms, obviously. So this is something that goes insidious and that is not visible to the naked eye,
Yeah.
and that's the problem. That's something like a heart attack. People often don't also know what it means, to what way it will impact them. So it's something that yeah, you know what it is, but actually the most people's knowledge stops there.
So,
Uh,
Ida, this is quite complex from the patient's point of view, the doctor's point of view. As
mm,
patients, we certainly feel like you know it all, so to speak, and we want to be guided. I appreciate that it's a long-term thing and the doctors don't want to ever feel like they've lent on us to do something. So how do you approach this conversation with getting people onto the most appropriate medication for them?
yeah, so I think very often they've already had a talk with the MS nurse and they did get like the typical leaflets that contain very generic information about all the disease modifying treatments. And that's fine because it's a good source of objective information. But what I do feel they lack is that they don't allow you to compare each of the treatments individually. And so it's more like in theory. So you can read one leaflet, you read another one, but then still, because they are very often designed and edited by different pharmaceutical companies, they don't provide the information in exactly the same way. So it's still difficult for an individual to understand what are the relevant differences between these disease modifying treatments.
Mhm.
So that's personally where I think the consultant comes in, or the MS nurse comes in, to bring to put these leaflets or the information they have absorbed from the leaflets into reality, to bring it into reality, to put it into practice, and to point out where the differences are. And obviously, my preference will always be for people to be on the most effective treatment. And I won't hesitate to state which one I think will be most effective in terms of halting their MS. But as I told already, it's not only about halting MS, it's about keeping people long term on treatment.
Yeah.
And so, what's the best? A very effective treatment they only will take for a year, or a medium effective treatment they will take for several years. So that's the sort of that's always something you have to keep in mind. And I also do think it's important that people feel their opinion or their beliefs are appreciated and
Mhm.
taken into account. And I think if you ignore that, um, yeah, that it will become even more difficult to guide that specific individual through the disease course.
I wish more doctors were like you because often over the course of time, it's felt like a minefield where I want to reach it. I expect, uh, I really do expect an answer because you're the expert, I'm not. And
Mhm.
feeling that I get an answer, like you said, you will make a statement about which you feel is the most effective one. Whether or not they choose it's a different thing. But the amount of doctors I've heard just saying, well, it's hard to tell. It's up to you. And
No, I don't
it's a
think it's
terrible
so.
burden on
That's
the patient.
personally, I don't think it's hard to tell which one are most effective. That's
Oh
very,
no,
very clear to me.
but that's
And
what
I
they
also
say.
think that's information you need to provide.
Mm,
There is no, I do realize that many of the treatments that we currently have, they haven't been compared head to head. So
mm,
it means that effective DMT number one hasn't been directly compared to effective DMT number two. At this point, we still don't know. And so, but what we do know is obviously how they behave
yeah,
compared to placebo or compared to the injectables.
yeah,
So I don't think, I think there is sufficient evidence to make claims about efficacy.
right.
So no, I have no issues doing that.
Mm.
Totally not. But I do realize that it's not all about efficacy. It's
Ida, I really appreciate you joining us on the MS Guide. I know that you talk for yourself. I just wanted to give patients a slightly different insight into it because it's not often that doctors will talk about things like this. So I really do appreciate it. Ida, thank you very much. Have a lovely day.
okay. You're welcome. Thank you for inviting me.
It's a pleasure.